Bismillah ar-Rahman ar-Rahim, Ibrahim Mabrouk, lecturer anesthesia. Today I will speak about an important topic which is shock, circulatory shock. My objectives will be definition of the circulatory shock, different types and differential diagnosis for the circulatory shock, stages and grades of shock, and lastly how you can diagnose the different types of shock and treatment of the cause of shock and treatment of the shock state, I mean the management of the circulatory shock. First, what is meant by the definition of the circulatory shock? It is a life-threatening condition in which hypoperfusion of the vital organs occurs. The vital organs like the brain, the heart, the kidneys, the liver. In the early stages of the circulatory shock, there is a vasoconstriction of the peripheral circulation and vasoconstriction of the non-vital organs like the skin, GIT, to shift the blood to the vital organs to maintain the perfusion of the vital organs. Then hypoperfusion of the vital organs will occur if there is later on non-compensatory shock. In the early state of shock, the clinical signs will be tachycardia of the patient, then hypotension of the patient, cold clammy skin due to vasoconstriction of the cutaneous vessels, then decrease in the urine output of the patient due to hypoperfusion of the kidney, then disturbed level of consciousness due to hypoperfusion of the brain, and the increase in the serum lactate level due to hypoperfusion of the tissues, causing lactic acidosis due to anaerobic respiration of the cells, which is one of the important signs for diagnosis of shock. Increase the serum lactate level more than 2 milliequivalent per liter. What are the causes, the pathogenesis of the circulatory shock? It is either due to decrease the fluid content of the blood vessels, hypovolemic shock, or affection of the pumping power of the heart, cardiogenic shock, or affection of the tubing system of the systemic circulation by severe vasodilatation in distributive shock. So if you see a patient with tachycardia and hypotension, I mean the patient with circulatory shock, you must put a differential diagnosis by the previous slide, either cardiogenic shock due to affection of the pumping power of the heart, or hypovolemic shock due to decrease the volume state of the systemic circulation, distributive shock due to vasodilatation of the systemic circulation irresponsive to the sympathetic system of the patient, or lastly, obstructive shock due to compression of the great vessels of the heart by something like tamponade, like tension pneumothorax, or obstruction of the great vessels by embolism, for example pulmonary embolism, affection of the afterload of the right side of the heart, decrease the cardiac output, and shock. What are causes of different types of shock? In the distributive shock, the cause of these vasodilatation irresponsive to sympathetic system, either sepsis due to systemic inflammatory response or neurogenic shock. The second type is a hypovolemic shock due to loss of the fluid content of the systemic vessels from bleeding, for example, or GIT losses by diarrhea or vomiting. In the third cause of shock, it is a cardiogenic shock, affection of the pumping power of the heart by different types of heart failure like ischemic cardiomyopathy. And lastly, the obstructive shock, obstruction of the afterload of the heart, so by compression or obstruction of the great vessels, so decrease in the cardiac output, like in the cases of cardiac tamponade by compression of fluid over the right side of the heart, or tension pneumothorax by compression by air causing shifting of the mediastinum and obstruction of the afterload of the heart, and pulmonary embolism, obstruction of the right side afterload causing decrease in the cardiac output and shock state. What are the stages of shock? early stage of shock, it is a compensatory state. The body compensates this state of shock to try to correct the shock and maintain perfusion of the vital organs. With the progression of shock and non-treated cause of shock, more progression will occur that will not compensated by the body. Then irreversible state of shock will occur that will not respond for treatment. You must treat the patient at the early state in the compensatory state. If the patient enters the progressive state, can be also treated easily, but in the irreversible state of shock, the treatment will be very difficult. In the compensatory state, the blood pressure will be normal due to the compensatory increase in the heart rate, tachycardia, to maintain the stroke volume and cardiac output of the heart. Respiratory rate will be increased, vasoconstriction of the skin, cold clammy skin, decrease of the kidney perfusion, so decrease in the urine output, mild confusion of the patient, and respiratory alkalosis will occur. With the progression of shock, there is decrease in the systolic blood pressure, 80 or 90 mm mercury or less. More tachycardia will occur, even tachyarrhythmia may occur like supraventricular tachycardia, respiratory rapid shallow breathing, and crackles may occur due to acute heart failure that will occur due to hypoperfusion of the heart or aspiration of the patient due to disturbed level of consciousness. The skin will be mottled and more decrease in the urine output of the patient, lethargy patient, and the metabolic acidosis from lactic acidosis. Irreversible state, that irreversible shock that may not respond for treatment. The blood pressure requires pharmacological support by vasopressors and inotropic support to maintain blood pressure. Heart rate, decrease in the heart rate or even cardiac arrest may occur. Respiratory state, need endotracheal intubation to shift the blood supply of the respiratory muscles, which is 25% of the cardiac output, to the vital organs, and intubation due to disturbed level of consciousness to prevent the aspiration of this patient. The skin will be jaundiced, the urine output, the patient will be anuric and may require dialysis if prolonged duration of shock, disturbed level of consciousness of the patient, and profound acidosis. How you can differentiate between different types of shock? You can easily measure the blood pressure of the patient, mean arterial pressure, and measure the CVP, central venous pressure of the patient, by insertion of the central venous line. But a specialized doctor can diagnose the cardiac output and systemic vascular resistance by using echo and other hemodynamic advanced monitoring. Hypovolemic shock. The mean arterial pressure in this patient will be decreased or normal. It can be compensated by tachycardia in the early state of shock. While in the obstructive shock, there is decrease in the mean arterial pressure by compression of the vessels. In the cardiogenic shock, there is a decrease in the mean arterial pressure or normal mean arterial pressure by the compensatory tachycardia. Distributive shock, there is decrease in the mean arterial pressure due to severe systemic vasodilatation, so mainly diastolic hypotension will occur. The cardiac output, there is decrease in the cardiac output in all of them except the distributive shock. In the distributive shock, it's called the high cardiac output failure. There is a severe vasodilatation. The volume of blood is normal, but it is shifted to the peripheral circulation, not for the vital organs, so it is high cardiac output shock. The central venous pressure in the hypovolemia will be decreased, and the obstruction will be increased due to obstruction of the afterload of the right side of the heart, will be reflected by higher pressure in the right atrium, will be reflected to high CVP. In the cardiogenic shock, due to decrease the contractility of the heart, increase the central venous pressure also, and the distributive shock will be decreased. Systemic vascular resistance will be increased in the hypovolemia as a compensatory state by sympathetic vasoconstriction of the systemic circulation obstructive shock, systemic vascular resistance will be increased or normal due to compression from outside. Cardiogenic shock will be increased in systemic vascular resistance due to sympathetic stimulation. In the distributive shock, there is decrease in systemic vascular resistance due to decreased vessel capacitance. I mean severe vasodilatation and loss of the myometrial contractility of the arterioles, so which will not respond to sympathetic stimulation, so decrease in systemic vascular resistance in the distributive shock. From history, you can diagnose the hypovolemic shock, history of bleeding or GIT losses, diarrhea or vomiting, and this patient will respond to fluid bolus easily. If you give patient IV fluid, the hypovolemia will be corrected. Then obstructive shock. So you can easily diagnose hypovolemic shock and can differentiate from other types of shock. The second type of shock, obstructive shock. If the patient has a tension pneumothorax, you can easily detect it, for example, by auscultation of the chest, decrease air entry in one side, and by chest x-ray you can see this jet black air around the collapsed lung. It is a tension pneumothorax. Also, the tamponade can be easily detected by history of cardiac surgery like valve replacement or CABG, and the echo by a specialized doctor can diagnose here echo fluid collection in the pericardium, this fluid compressing the right side of the heart. Also, you can diagnose the pulmonary embolism by history of DVT, cyanosis of the patient, and echo for this patient, and the gold standard is CT angiography. So you can differentiate between obstructive shock and hypovolemic shock. It is important to diagnose the cause of shock for do the correct treatment for this patient. In the cardiogenic shock, you can easily diagnose this patient by history of chest pain, of angina, narrow pulse pressure, the blood pressure will be, for example, 90/70, and ECG, ischemic changes, for example, and you can auscultate the base of the lung and detect fine basal crepitations of the heart failure, and by echo you can detect defective contractility of the pumping power of the heart. If you give a fluid bolus for this patient, more shock occur due to you increase the load over this diminished pumping power of the heart. So not any patient coming for you with shock, never give him fluid unless you confirm the diagnosis of shock. Then the distributive shock, you can diagnose it from history of severe pain or allergy in neurogenic shock, or from history of fever. There is a source of infection like abdominal abscess, for example, or appendicular mass, and wide pulse pressure. The blood pressure be, for example, 100/30 or over 40 due to diastolic hypotension due to severe vasodilatation of the systemic circulation. So it is a septic shock. So this is a diagnosis of different type. After you diagnose the cause of shock, you must start the treatment. For example, hypovolemia, give IV fluid or blood according to the cause of hypovolemia. Obstructive shock, pneumothorax, can easily treated by wide bore cannula inserted in the second intercostal space underwater seal. Tamponade can be easily treated by ultrasound guided pericardiocentesis. Pulmonary embolism is easily treated by thrombolytic by specialized doctors. Cardiogenic shock, treatment of MI, for example, by PCI, cardiac catheterization, but in non-specialized center we can give thrombolytic. Inotropic support to support the pumping power failure using inotrope like dobutamine or adrenaline. In distributive shock, neurogenic shock can be treated by supportive treatment, ABC approach. Anaphylactic shock, the drug for choice is adrenaline, can be given 0.5 mg IM adrenaline, or if a specialized doctor like anesthetist or intensivist can give the adrenaline IV. And you must treat the cause of anaphylaxis by antihistaminic. In septic shock, according to the different guidelines of sepsis, start antibiotic immediately, give vasopressor for this patient, noradrenaline, even if more or less normal blood pressure, and give him fluids. The conclusion, if you see a patient with shock state and hypoperfusion of the vital organs and easily diagnosed by signs of shock, you must diagnose the cause rapidly. If it is distributive shock like sepsis, treatment you can diagnose from history. Anaphylaxis also easily diagnosed. You must start the treatment immediately. If the patient hypovolemic, you can diagnose by history also of bleeding or GIT loss, start the treatment by IV fluids. If the cause is cardiogenic shock, the easily diagnosed by history, examination and echo, so you must give inotropic support and treat as a cause of heart failure. If the patient has obstructive shock, you can easily diagnose by examination, chest x-ray and echo and history, so you can treat pulmonary embolism by thrombolytic, tension pneumothorax by needle decompression, and cardiac tamponade by pericardiocentesis. And thank you.